Hello, everyone. I am Stanley Sanjur, the Education Operations Manager for MPRO for tonight's program. A warm welcome to all of you. Tonight, I have the great pleasure of introducing our guest speaker. Originally from Seattle, Dr. West received his MD and PhD in biostatistics from the University of Ohio in 1999. He completed residency and chief residency in internal medicine at Mayo Clinic and joined the faculty in general internal medicine in 2004. He is currently professor of medicine, medical education, and biostatistics at Mayo. He directs the evidence-based medicine curriculum for the Mayo Clinic Elix School of Medicine and is an associate program director within the internal medicine residency program. He is also the assistant dean for GME scholarship within MCSGME. Dr. West's research has focused on medical education and physician well-being, and he is co-director of the Mayo Clinic program on physician well-being. His research has been widely published in prominent journals, including Lancet, JAMA, Annals of Internal Medicine, and JAMA Internal Medicine. Dr. West is passionate about physician burnout and has been a crusader in researching the subject, particularly in how to enhance physician well-being. It is truly my honor for MPRO to have Dr. West present for us this evening, and it is my pleasure to introduce to you Dr. Colin West.
Thank you, Stanley, and a special thank you to Jerry and Tristan as well for the invitation. We had hoped that this would be part of an in-person event several months ago, but a certain pesky virus got in the way. I'm going to share my slides and my screen here in just a moment, but I'd like to begin by acknowledging and thanking each of you that's been involved in being on the very front of the front lines of COVID-19. In so many respects, the rest of the country watched what was happening in New York with sympathy, with empathy, but also learning. And I can't imagine what that must have been like for all of you dealing with all of those events. But I think the country is better because of what you were able to demonstrate. So again, I acknowledge that and thank you. Let me all right, so my slides should be coming up on your end. We'll talk about physician well-being in 2020, COVID-19 and beyond. I will mention that if there are questions, my understanding is you all will be muted during the presentation to try and keep some of the chatter back and forth controllable. I suspect after the debates last night, all of you can understand why keeping the back and forth down might be advisable. That said, when we are done with the talk, anything that comes up in the chat or any other Q&A at that point, I will stick around as long as anyone wants me to. I won't be able to see the chat questions from my single screen here as they come up. So Stanley, if there's something that comes up that I need to address urgently, please break in and let me know. Otherwise, I will work through my slides and we will make sure that we address questions and concerns at the end. I have no financial disclosures. Additional contact information is on this slide. It will also be on my last slide. And I've made a PDF of my slides available through MPRO so that anyone who's registered for this will be able to see that for some of the links and other information that I share. My email is here and then also my Twitter handle. I won't read the learning objectives, but we're going to talk about some background epidemiology. We'll talk about what we know about a framework for solutions, and we'll talk about local practice and organizational leadership efforts that I think are crucial to promote well-being. We're not just going to talk about all of the negative sides of burnout that everyone's also familiar with. I want to also talk about how we bend this in a more positive direction. So how do we help physicians feel engaged and connected in their practices? How do we help physicians flourish and thrive? The focus of my presentation will be on physicians, but other healthcare professionals and clinicians on the front line have very similar experiences, and the same content will generally apply. And of course, all of these objectives have been amplified as we think about the impacts of coronavirus. And we'll talk a little bit about that as we get towards the end. But it's important to mention that physician well-being was a concern long before coronavirus hit us. So the core principles really have not changed. In many respects, the virus has amplified these difficulties. And we'll talk a little bit about that as we go. So what is burnout? Since we're going to talk about this a fair bit, it's important that we have a common understanding of what this is about. From a research standpoint, burnout is a work-related phenomenon that has three primary dimensions: depersonalization, emotional exhaustion, and a sense of low personal accomplishment. In our work, the sense of low personal accomplishment has been less associated with key outcomes, so we have focused more on depersonalization and emotional exhaustion. So what are those? Emotional exhaustion is illustrated by this phrase: I feel like I'm at the end of my rope. This is emotionally feeling husked out, worn out, nothing left to give your patients. These are measured on a continuous scale, but for ease of communicating, we've demonstrated that experiencing this kind of a feeling at least once a week is associated with negative consequences. And so that frequency can be used as a dividing point between less serious and more serious burnout symptoms in the emotional exhaustion domain. Similarly, depersonalization is illustrated by this phrase: I've become more callous toward people, particularly in medicine, callous toward patients, since I took this job. And if we think about the professional ideals that we all hold, becoming more callous towards our patients is not part of what we want to be. We are pushed toward that. It's not who we were when we started medical training. It's not who we want to be in our practice. But for many people experiencing these symptoms or these feelings, they're not sure how to get out of this. What happens at the start of medical school is actually interesting in that medical students have lower burnout rates, lower rates of depressive symptoms, and better quality of life in every measured domain relative to their age-similar college graduate peers. So there's sometimes been a mindset that, well, we're recruiting the wrong people into medical school, or they're already damaged goods. The data do not support that. We are actually recruiting, and we continue to recruit, very dedicated, bright, generally well trainees. Now, certainly there are some personal characteristics, including perfectionism and dedication, that if taken too far can have negative consequences. But at the starting point of medical school, we have the best of the best. By the end of the second year of medical school, this has reversed. And now our second year medical students have higher burnout rates, higher rates of depressive symptoms, and not shown on a slide, lower quality of life scores in every measured domain. So there is something that we do to our medical students as part of our educational process, part of our system, that affects their well-being negatively. And it's important to note that some of this is happening even before most of our medical students have ever seen a patient on the wards. When we look at practicing physicians, we've studied this for a decade now nationally with the American Medical Association and more recently with Stanford University. And what we see is that burnout rates overall, as evidenced at the top in the red line, have hovered around 50%, 45 to 55%. They ebb and flow a little bit, and we will be looking again later in 2020 to see if we have more information. Some of that will reflect COVID effects. Some of that will affect simple temporal trends. We'll see what that looks like. But these numbers are important because a substantial proportion of physicians are dealing with these symptoms. Burnout from 2014 to 2017 seemed to have improved slightly, but it's important to note that other dimensions of well-being did not improve. Dissatisfaction with work-life balance, still worse than it was in 2011. and rates of a positive depression screen have slightly but systematically increased since 2011. 42% of our physicians nationally screening positive for depressive symptoms. This does not mean that 42% of our physicians are depressed, because the screening tool is a screening tool, but probably a quarter to a third of these would be diagnosable with major depressive disorder if we formally assessed them based on what we know about the performance of this tool. So that's certainly a mental health standard that is not acceptable nationally. Sometimes people wonder, well, is this unique to medicine? We're very privileged in this profession. We have generally stable incomes. We generally enjoy good status. Our patients generally respect us highly, even if it may not seem that way every single day of our practices or with every single patient. So, maybe this is something that we're experiencing, but it's worse for everybody else. Well, it turns out that's not the case. Physicians have higher burnout rates and higher rates of dissatisfaction with work-life integration than the general employed population. This also holds for other highly trained individuals who have jobs that require advanced degrees. Collectively, there is something different about physicians from a negative standpoint. And this forms a bit of a paradox, because we have this incredibly rewarding, meaningful profession. And yet, those engaged in this profession are not able to tap in to that meaning, value, and purpose in the profession the way they ought to. What are the consequences? Why does this matter? Well, one slide to summarize a vast amount of literature, but this matters in short to every stakeholder in our healthcare system. So from a patient care standpoint, burnout has been associated with medical errors, impaired professionalism that patients experience, reduced patient satisfaction, and even experiences of racial bias, both in patient scenarios and in the general population. From a health system access standpoint, from a patient access standpoint, physicians experiencing burnout are more likely to reduce their FTE and clinical hours or leave their jobs. That has massively disruptive impact on patients who are looking for some kind of continuity in a very disjointed healthcare system to begin with. For physicians themselves, medical knowledge is adversely impacted. Mental health, obviously, there are serious consequences, and that's certainly been in the news for trainees and practicing physicians alike in the New York area. Even public safety concerns, motor vehicle crashes and near misses, after accounting for fatigue. So isolating this to an impact of burnout. And in total, if we just look at physicians, just look at burnout, and just look at the costs of staff turnover and reduced FTE, an analysis conducted with the Harvard Business School estimated that the costs to our healthcare system exceeded $4.5 billion a year. That's just physicians and just these dimensions of burnout. So the total costs for our healthcare system are much, much greater than this. This works out to about $7,600 per physician in the United States, which is a number I want you to keep in mind as we think about the return on investment for solutions, because we are spending $7,600 per physician as a country right now as a lowball estimate, without that amount appearing in any budget as a line item for any organization in the country. We're just letting that fall out as if it's change disappearing out of a hole in our pockets. So we've cast this as a public health crisis just based on the prevalence numbers. At any given time, we have more than 40,000 medical students, 60,000 residents and fellows, and 500,000 physicians in the United States dealing with burnout symptoms at least once a week. If we look at nurses, we have a recent paper that we looked nationally at nurses for the first time, 3.3 million nurses in the United States. The collective burnout rate among nurses is about 35%. So we're talking about over 1 million nurses dealing with burnout symptoms. So we're talking about, without exaggeration, millions of healthcare professionals in this country who are dealing with the same consequences for our entire healthcare system. And hopefully that speaks to the magnitude of this issue and why it's relevant. It also speaks to the importance of thinking about what the root of this issue is. Is this grounded in individual shortcomings, or is this really more rooted in our systems? And my assertion, which I believe is supported strongly by the data, is that this is primarily a system issue. Our individuals in our healthcare professions are, for the most part, extremely talented, highly skilled, and very dedicated. And they are working in systems that do not allow them to optimize their performance on behalf of our patients, ourselves, and our healthcare system. So if this is grounded in systems, do we have any pathways, do we have any maps to help guide what the solution should look like? And if we think back about 20 years ago, To Err is Human came out from the Institute of Medicine, what is now the National Academies of Sciences, Engineering, and Medicine. And To Err is Human turned patient safety on its ear. Prior to 1999, when this was released, the majority of medicine viewed patient safety and medical errors as individual failings. And we had M&Ms that raked people over the coals for their shortcomings as individuals. To Err is Human said, okay, yes, there are some human fallibilities here, but the primary root of patient safety concerns is a system-based process that does not allow highly skilled individuals to achieve the best possible outcomes. Paul Batalden famously said, every system is perfectly designed to get the results it gets. So if we think about our healthcare system with nearly 50% of physicians experiencing meaningful burnout symptoms at least once a week, with consequences for patients, physicians, and the healthcare system as a whole, our system is actually designed right now to deliver that result. That's a system that needs to change. One of the theories behind burnout that informs some of our solutions is the job demands resource model. And this is really quite simple. But the idea is that burnout results when there is a chronic imbalance between job demands and the resources available to allow people to meet those demands. So if demands are excessive, they push people's tolerance down. If resources increase, it lifts people up. And that's really the push-pull for being able to thrive versus fall in our work. This relates very closely to human performance models. And on the left of this slide, there is something called the Yerkes-Dodson law that some of you will be familiar with. In medicine, essentially everything we do, even the tasks that we think are simple, are actually quite complex. And for difficult tasks, like everything we do in medicine, it turns out that if you have too much stress, what Yerkes and Dodson termed arousal, but which is really stress or stimulation, performance suffers. Now, we recognize as medical professionals that some degree of stress promotes growth, and we actually thrive with some degree of stimulation in our work. That promotes optimal performance. But when we're pushed beyond that point of the curve, performance actually suffers. This is also true if we think about the Frank Starling law in cardiology and sarcomere stretch and stroke volume. And in human stress overall, there is a sweet spot where we optimize performance. And that's where we need to be working as physicians. But far too many physicians across the country are being pushed by their systems and their practices to be on the far right side of this curve, where they're in the chronic exhaustion stage of things. And we have to start to recognize that that actually hinders performance, especially in the long run. We may be able to sprint for a short period of time, but medicine and a medical career is a marathon, and no one can sustain a sprinter's pace across a marathon distance. And it's bad for our healthcare system on the whole. This idea of optimizing performance in the long run is relatively foreign in thinking about medical practice. And to optimize our performance, we need to intentionally and consciously shift our place on this curve. And we'll talk more about that as we talk about leadership models. When we think about the drivers of distress and well-being, there are a number of broad categories. And at the center of this honeycomb is meaning in work, or as I would expand it, the MVPs of well-being: meaning, values, and purpose. Everything feeds into our sense of meaning, values, and purpose because we are mission-driven in our work. The vast majority, I won't say all, but essentially all medical professionals are in medicine because there is some part of themselves that is driven by helping others. And yes, there are financial compensations and status and other things that do play into it, but at its core, medicine is about helping others, and we buy into that. We're committed to that. There are other factors that sometimes get in the way. So excessive workload, we know, drives burnout and distress. Lack of control at work, inefficient resources at work. Many people will think about the electronic medical record. In practices where the electronic medical record, clinical support systems help physicians focus on their patients, they have better well-being. Where those medical systems interfere with interactions with patients, well-being is less optimal. Organizational culture, or your local practice culture, if you're relatively self-employed, is crucial, and a sense of community and social support as well, which has never been more challenged than during the pandemic. One example to illustrate inefficiency at work in the United States. So this comes from a paper published in Annals of Internal Medicine in 2018. And this is a study of documentation length in characters for ambulatory routine presentations for patients. And these are the average characters per ambulatory note for practices located in the United States or internationally. Many of these international practices were in Europe, but they were spread across the world. There are two things to note about this slide that I think are compelling. The first is that if you look at the average note length, for international practices on the left, the average note length was somewhere maybe around 12 to 1400 characters. The average note length in the United States, 4,000 to 4,500. So 3 times the note length in the United States. The other even more compelling point for me is that there's actually no overlap in the mean note lengths for the international or US practices. So the international practice with the longest average note length still had shorter notes than the shortest note practice in the United States. Now, if we could look at these data and say, you know what, we have longer notes in the United States because it helps us deliver better ambulatory outcomes, then maybe we could justify this as serving the needs of our patients. But all of us recognize that by every quality metric, we do not actually deliver better quality outcomes for routine ambulatory conditions in the United States relative to many other countries across the world. We're quite middle of the road, actually, for routine medical care. We do brilliantly well with extreme care, highly technologically demanding care. We do average for ambulatory care. So who are these notes serving? They are adding major clerical burdens for physicians, and they're not helping patients achieve better outcomes. So why are we doing it? And that's a question that really just hangs out there without a good answer, certainly not an answer that supports physician well-being. So as we think about these drivers, they inform strategies, and I'm going to talk in general terms to begin with. First, from an individual strategy standpoint, as much as I've said that the system is crucial and is driving most of our concerns, we do still have an individual responsibility to control what is within our sphere of influence. So taking time to identify our own personal values. If meaning, values, and purpose is central to well-being, how do we take a step back and think about, well, is what I'm doing purpose-filled? How do I maximize the effort that I'm contributing in things that give me meaning and will help me sustain a career for my patients? That requires intentionally stepping off the treadmill sometimes and taking stock of what we're doing. Personal wellness activities are important. They're very individual. What works for one person may not work for another. Self-care is important, but that takes different shapes for different people. For some people, spiritual practices are central. For others, they're peripheral. But what's important is calibrating your distress level and having a sense where you are on that stress curve. And physicians are terrible at this. My colleague Lottie Derby has worked on the Physician Wellbeing Index. I'm not involved in that tool, so I have no conflicts to disclose there. But that index, which I'll share more in a moment, in fact, here's a little bit of an introduction to it, is a 9-item, very quick tool. There's a website listed on this slide. It will also be on the next slide, where people can punch in answers to questions with your own login, your own ID password. No one else can see your information. And it allows you to compare your answers to national normative benchmarks from large-scale surveys. When this has been looked at in practicing physicians, and I'll give one example from practicing surgeons nationally, 90%, well, I'm sorry, I exaggerated, 89.2% of surgeons rated their well-being as at or above average for their peers. So think about that. 90% of surgeons think they're at least average for their well-being relative to their peers, when we know that that number should really be close to 50%. So we overestimate our well-being. Even more concerning, 70% of practicing surgeons who were in the bottom third for well-being thought they were above average. So our ability to self-assess our own distress is not great. As much as sometimes physicians think they're complainers or are labeled as complainers, when push comes to shove, we actually self-assess as being more well than we are, according to validated instruments. This is a bit more about the Physician Wellbeing Index. The website is here. It is free for individual use, and again, completely confidential, but it will give you a report back with some benchmarks. All of you will have these slides made available to you. This is also being recorded, so as I move quickly, if you don't catch something, you will have other opportunities to take a look at this, but there are self-calibration tools that are out there. So I say a few words about individual strategies, but that's about all I'm going to say about them. They are relevant, but they cannot be the only focus. So why is that? Well, if we exclusively focus on the individuals, we risk deepening cynicism by sending the message that all physicians need to do is toughen up to cope with what is in fact a toxic working environment, rather than dealing with the environment itself. And that's frankly blaming the victims or gaslighting, as illustrated by this painting of the canary in the coal mine who is perhaps told, well, why aren't you wearing a gas mask, instead of let's clear the toxic fumes from the coal mine itself. We have some data on this now. Published earlier this year, we worked on a national survey looking at resilience, comparing physicians with the general US working population. And I won't belabor the numbers here, but I will point out that physicians had a higher resilience score than the general employed working population. That's important. Physicians are not resilience deficient. In fact, we bring a great deal of resilience to the table, which is not surprising if you think about it, because what our work demands, what our training demands, has required resilience and grit every step of the way. So to me, it's not surprising that we are actually more resilient. When we look at total resilience scores in relation to burnout, it is true that physicians with higher resilience have lower burnout rates. So resilience is helpful. It helps you cope with your local working environment. And those are skills that are relevant for physicians. But it's also important to note that the burnout rate for physicians with the highest possible Connor-Davidson resilience score in our study, 30% of those physicians were still experiencing burnout. So resilience does not get you out of the woods. It does not prevent burnout exclusively. It helps, but it's certainly not enough. And it's disingenuous for healthcare systems to suggest that all physicians need to do is go to resilience training. Now, I support stress management and resilience training as part of our individual toolkit that we can bring to bear. But it cannot be alone. It needs to be on a menu with many other sets of solutions that we'll talk about in the next 10 minutes or so. So shifting to that then, what can organizations do from a broad standpoint? Well, if meaning, values, and purpose are central to well-being, then what do your practices do to promote meaning-filled, purposeful, and value-laden careers? That's on your organization, on your practice, on your administrative functions to put you in situations where meaning, values, and purpose are optimized. That means providing adequate resources and listening to what physicians say they need to allow them to maximize their engagement for their patients. Flexibility and a sense of control of voice is important. Work-home integration is important. I am acutely aware that all of you are watching this on an evening during the work week. I thank you for your time, but I'm also mindful that you are incurring a debt to your home life. And that is a debt that I urge you to repay for yourself and for your loved ones. And then again, meaning in work. We've written about this at Mayo with a set of organizational strategies. I will emphasize that these are aspirational. We do not execute all of these well at Mayo, nor anywhere else in the country. There are hotspots that are better or worse for some of these. Acknowledging and assessing the problem is first. You can't address well-being and distress if you're not willing to look at it directly. Leadership's important, community at work, flexibility and work-life integration. There are some aspects of flexibility that many practices have seen improve actually as part of the pandemic as we think about telemedicine. I've experienced that to some extent in my own Mayo practice, where being able to schedule visits with patients that don't require the patient to be physically here and don't require me to be adherent to a specific set schedule so that we can mutually come up with something that's agreeable. And organizational science and so on. I won't read the list to you. The next slide is one that I don't expect anyone to read. It is extremely busy, but it's busy on purpose. I want to make the point with this. Oh, I lied. It's not quite yet. This is much easier. Here's the busy slide, and then I'll skip back. This is meant to show that there are many, many solutions that are out there. And this will be available in your slide set in a tiny form that you can't read probably, but the reference is here. And if anyone wants a copy of this paper individually, I'm happy to provide it. Just send me an email or send me a DM on Twitter. But there are many factors across, or many solutions across many domains that are available. What can you do in your own personal practice to keep it simpler? I recommend starting with what are some individual solutions and what are some practice level or organizational solutions. So what can you do for workload? What can you do for work efficiency, work-home integration, autonomy, meaning and values? And you think about your own menu. It might end up looking something like this. This is a sample. It'll look different for different people. And you might envision that the only solution you can come up with for controlling workload individually is to reduce your workload by going part-time. Maybe that is the only solution for you. Organizationally, we can think about workload in terms of how we define success. How do we set our productivity targets? Why do we set our productivity targets where they are? And are they sustainable and consistent with well-being and long-term patient care outcomes? Meaning and values, you can read the rest of this for yourself, but you identify here what are the 1, 2, or 3 hotspot areas that you think are the biggest drivers of your own distress or would be the biggest proponents of your well-being. And let's say, hey, I really struggle with work-home integration. So what can I do individually to promote work-home integration and balance? What can I work with my practice on to promote work-home integration and balance? And maybe that's where you put your emphasis to start. It'll be different for different people, different practices, and different organizations, but you can organize your thoughts this way. Again, the super busy slide, and there are other solutions posted at many Alphabet websites across various stakeholders, graduate medical education, internal medicine specifically, the AMA Steps Forward modules, and the National Academies of Science, Engineering, and Medicine, which has last fall published a consensus report on clinician well-being, which is a more than 300-page document, which is really now the go-to, just as To Err is Human was for quality more than 20 years ago. So I'm going to spend the remaining time talking a little bit about leadership and guides or roadmaps for how to approach these challenges. So when I talk about enlightened leadership, I want to extend from the triple aim to the quadruple aim. Most of us are familiar with the triple aim: improving the health of populations, enhancing how patients experience their care, and reducing costs. All critically important, and none are achievable without attention to the quadruple aim, or the fourth leg of this, which is improving the work lives of our healthcare professionals. Physician well-being then must be cast as a quality marker, which requires that we evaluate the impact of policies on all of our goals. How do we define performance? How do we define success? Is it that we achieve a 10% margin in a given calendar year, even if 20% of our physicians leave the practice after that year because of burnout and distress? Well, I will tell you that some in the business world view employees as replaceable. And this is one of the challenges. Is medicine a profession with larger aspirations and goals and larger mission, or is this purely a transactional business? It is not the latter, in my opinion, but if we are going to follow an exclusively business model, then sure, aim for the greatest quarterly productivity and your employees aren't going to be with you very long. I don't think that's good for our healthcare system on the whole, however. We wrote a couple of years ago about the Charter on Physician Well-Being. This gives a list of guiding principles and key commitments, and we've had sign-off on this from dozens of major organizations across the country. Most of this is mom and apple pie. It's basic. Effective patient care both promotes and requires physician well-being. We're in partnership with our patients. We're also in partnership with our entire healthcare team. Medicine is a team sport. This is not just about physician satisfaction. This is about physicians working well in an interdisciplinary team where everyone on the team thrives. It's a quality marker, and there are individual and organizational responsibilities. The key commitments range from higher level societal commitments to individual commitments, from practicing and promoting self-care to fostering trustworthy and supportive cultures across all of medicine. Point 7 is crucial: prioritizing mental health care. This requires that we destigmatize help seeking. And we've written about how many state licensing boards and their questions for licensing and renewals are probably in non-compliance with the Americans with Disabilities Act, and they discourage people from seeking help because they ask questions, for example, about have you ever been diagnosed with depression, anxiety, or another mental health concern? If you are not currently impaired, that question is irrelevant to your ability to take care of patients. And as a result, I am not a lawyer, but as a result, many feel is an illegal question. We have pushed state medical boards across the country to modify those licensure questions. More than 2/3 of the state medical boards in the country were not in compliance when we published this paper in 2017. 10 of those states have since fixed their licensure, but we still have about 20 states left that have dragged their feet, but we need to do better. As I mentioned, the charter's been endorsed by many groups. And then just a word or two about the pandemic. All of you have been living this, so you know this better even than I do. But there are unique sources of anxiety among healthcare professionals during the pandemic, so that all of these drivers of distress or well-being still exist and are now supplemented by additional concerns. Concerns about personal protection, concerns about our family's well-being, concerns about whether we will have proper access to protective personal equipment. How will we be cared for? How will we sustain our efforts? And what many of my colleagues in the New York area have shared with me, which is a concern as we head into the fall, is that there's this honeymoon period where everyone really doubles down in the midst of the pandemic, because it's what we do, we step up. We can sustain that sprint for a period of time, in fact, longer than most people would ever have a right to expect. But at some point, we wear out, we become exhausted. And if there is a major uptick, a second wave, as some have said, or a resurgence with flu season, we need to be very, very careful that already worn out physicians and other healthcare professionals are going to need even more support. And we need to be very intentional about that. When we've looked at employee well-being efforts, we need to think about different worker groups. So there's the group that is infected themselves, has health problems themselves. How do we take care of them properly? Isolation is crucial for those people as an adverse effect, actually. They are disconnected from their friends, their family, their coworkers. So beyond the physical health issues, there are additional mental and emotional issues as well. Displaced workers who can't work in their usual environments. They're working in different hospitals. They've had to work from home. They've been furloughed. Those have massive implications. The new teleworking that people are trying to sort out, there are factors for personal health, social support, internet access. My kids are distance learning because of school district rules until rates in Minnesota get down below a certain level. But what about families who don't have the same kind of internet access? For most physicians, this is less of an issue because of our status and our incomes. But for many other healthcare professionals, these can be challenges, especially those living in more expensive parts of the country. And across all of these different domains of well-being, we're not just thinking about physical health. We need to think about emotional well-being, meaning in work, financial well-being, and be very holistic and broad about this. So in summary, when we think about physician well-being, we have a professional obligation to act on these issues. This is a threat to our profession. It was a threat before COVID-19. It will continue to be a threat during and after COVID-19. It's actually unprofessional for us to allow this to continue. Physicians are inherently altruistic. It's part of the oaths that we all take. But altruism can lead to a point where we cannot sustain it. And we can be altruistic in the short term and not be there for our patients in the long term. And I don't think that serves our longer term goals. So we need to incorporate that into our definitions of sustainable professionalism. This requires that everyone be rowing together. We need to be able to assess distress, both individually and across our practices. This needs to become a metric of institutional or organizational performance, part of our personal and leadership dashboards. We need to move beyond judging our practices simply on RVUs and revenue and think about a longer term sustainability model. And that's a big, big lift given our current healthcare finance structure. But we've certainly demonstrated that assessment of distress can be anonymous and yet actionable. The toolkit for these issues is diverse. It will contain lots of different tools. There is not just one solution. Every individual, every practice is different, but many different approaches offer benefit. When we understand the drivers and we address those drivers, we can right-size solutions that will help people shift from distress toward engagement, thriving, and flourishing. And if we keep our eye on these drivers, this honeycomb in particular, I think is very helpful. And I would encourage you as individuals and in your practices to be particularly persnickety about optimizing meaning, values, and purpose in your work. It will help you and it will give your patients what they need as well. And that's really what your practice administrators, whether they are physicians or not, should be looking for in healthcare. If those are not the goals, then those goals need to be revisited, and people really need to look in the mirror carefully to think, why are we in this? Because the goal needs to be that quadruple aim. What's good for patients, what's good for our healthcare professionals, what's good for our healthcare system as a whole. This is my email, my Twitter handle again. PDF of the slides will be made available to everybody. I will stop there. I will stop sharing here in just a moment. I will then be able to see some of the chat, and we can engage in whatever degree of conversation people are interested in. I'm mindful that it's 8:15 Eastern time, and many of you have the rest of your lives to get to. I will be in no way offended by people who sign off at any point along the way, but I'll be available as a resource. So with that, I will stop, and I will let Stanley open the floor as he wishes. He'll be in charge. While he's doing that, let me just take a couple of the notes that are in the chat here that I'm seeing. So the 30% of physicians who are resilient yet also suffering with burnout symptoms. So with help-seeking stigma and a physician who is already resilient, might that stop people from seeking help for their burnout? And I think potentially it could, because sometimes physicians who are resilient may be less self-aware that they're dealing with distress, because they're able to repeatedly bounce back. That's what resilience is responding, bouncing back in the face of adversity. So I would say, whether people are resilient or not, those self-calibration tools are really important to allow people to get a sense of where they are. We don't have great self-calibration tools for every dimension of well-being, but eventually I'd like to see a menu where people can have sort of a self-help menu where you can dip in and spot check where you are with things and recognize where your hot spots are. A second one here, health insurance companies are contributors to regulatory burden. So are there efforts underway to control or curtail that burden? Is there reason for optimism? Great question. Yes, there actually is reason for optimism. I'm going to temper that slightly because the pace has been slow. But I will say, and I mentioned this when I spoke in person at what was then PRI a couple of years ago, there are branches of major organizations nationally that are actively engaged with organizations like CMS and JACO in regulatory burdens. And the AMA, with its branch on physician satisfaction under Chris Sinskey, has been meeting with those groups for the last couple of years on a regular basis. What's interesting about the regulatory burden is it comes from multiple places. So CMS has been taken to task by Dr. Sinskey and others for having unclear regulations that invite misinterpretation. And that is being worked on. Slow progress, but it is being worked on. For those that work in education, for example, there have been recent rule changes that predated COVID that allowed medical student documentation to count towards billing. So for those that are working in education, that's a really big deal, because in the past, medical student documentation counted for nothing. You had to document everything independently yourself, which is duplicative. You take that away, and groups that are working in education roles, it's a big alleviator for them. Obviously, that doesn't help people who aren't working with learners. So we need to do more for groups that are working in private and non-education focused practices. But it's a sign that change can happen. Another interesting point there, however, is how much of the regulatory burden is self-inflicted by our own practices. So we think about risk mitigation in our documentation requirements. I can certainly speak to this with my own organization. I'm biased. I think Mayo Clinic is a great organization. I've been here for 20 years. However, there are certainly risk mitigation and compliance areas where our burdens are set to minimize liability risks with really very little benefit and substantial additional clerical burden. That is self-inflicted, because when those regulations are brought to CMS or to JACO, when they read them carefully, what they told Dr. Sinsky was, why would you do it that way? That's just silly. We don't require that. And Dr. Sinsky would say, well, but your regulation's a little unclear. Can you write in your regulation exactly what you require? And so that's where part of the dialogue comes. So yes, I am cautiously optimistic. Change is afoot, but we need to keep pushing. The last thing I'll say to this question here is there are also a number of pieces of legislation. They have come from Virginia, they have come from Illinois, and there's a third one I can't remember, it might be California, that have been put forward. The timing has been challenging because of focus on pandemic and all of the politicized issues that are obviously front and center right now. And that's not meant to be a biased statement because it doesn't matter which party you affiliate with. The politics has been front and center. So the timing has been challenging, but there has been quite a bit of push for additional protections and relief for healthcare workers broadly. The Virginia legislation was brought forward in honor of Lorna Breen, who obviously in New York, all of you are familiar with, and her family has been very involved in pushing for change. And, you know, there's very little that, if anything, that one can say positively about a tragedy such as what affected Dr. Breen and her family. But rather than having it be completely negative, if we can have that be a lever for positive change, that's what her family has been pushing for. And so there is now in the halls of Congress, increasing awareness of the impact of healthcare professional distress on our healthcare system, making both the moral argument and, quite frankly, the financial argument about how this is not good for our country. Next question on the chat. Please keep working on the licensing boards. It's time for licensing boards to not fault us for seeking help. Amen to that. And we are absolutely pushing hard for that. We had a fascinating discussion after our paper came out with a state that I won't name, where they actually filed a complaint against us, not a legal complaint, but a complaint saying we had misrepresented their state. It was fascinating because we said, well, we used the documents that we could obtain that are published on your state medical board's website that all of your physicians in your state access. So if we're misrepresenting, it's because your paperwork is incorrect on your own state medical board's website. They then went back to their own legal team, who informed them that in fact we were right. They were not in compliance. And if they wanted to change their paperwork, they could do so. They simply had to vote as a state medical board to do it. So some state medical boards aren't even fully aware of what their language is or the impact that it has on help seeking. So the more that we can highlight this, the better. There have also been efforts. Eileen Barrett is an internist in New Mexico. She effectively lobbied for New Mexico to change their language. So at the state level, there are opportunities to continue to push. This is really not a national language issue. It's a state medical board, one at a time sort of issue. So in your own local areas, it's worth looking at your state medical boards where you keep your licensure. And if that language asks about history of physical or mental illnesses, not present impairment, then that is questionable at best, quite possibly illegal. And those discussions I would encourage with your state medical boards. A new chat question, any suggestions on how to offer support to help-resistant physicians? So what about didactics, one-to-one peer support? How do we balance vulnerability with, physicians, who may be vulnerable in different situations? And I would say this is very individual. The first step, I think, is encouraging awareness in a confidential manner. So if everyone was encouraged to self-calibrate, I don't care if you use the Wellbeing Index, it's free. It's not going to make my colleague, Dr. Derby, any money at an individual level because there's no cost involved, but any other tool would be fine as well. And if people simply were able to complete those confidentially themselves, maybe it would spark a little bit of, oh, you know what, maybe I'm not doing as well as I thought. I also think that peers and leaders can promote this from a positive standpoint. Why did we all get into medicine in the first place? And is there a gap between our goals and what we're doing and experiencing now? And how can we positively fix that gap? That's a supportive approach, not a blaming approach. And it's very, very tricky when there are potentially punitive manifestations or ramifications, I should say, when we're dealing with state medical boards, or a question that's also come up in terms of litigation around these issues. So the more we can do this confidentially, the better. To that end, burnout is not a DSM-5 diagnosis, and that's important because people can seek help for burnout without it being a medical diagnosis. It is a ICD-11 listed entry, but the World Health Organization has been very careful to be clear. It is not a medical diagnosis. It's an experience. And so people should feel less stigmatized about burnout and stress than they might be around depression or suicidality. And that may be an entry point to helping people, again, thrive in their careers, getting back to meaning and having a positive bent to this. The litigation issue, we know that physicians that have been involved in a lawsuit commonly regard that as the single most negative aspect or experience in their medical careers. I don't have great solutions for folks that are in the middle of that, other than, as much as the lawyers will tell you to become isolated and share nothing with anyone, that is absolutely the worst possible advice you can get from a well-being standpoint. I'm, again, not a lawyer, so from a legal standpoint, it may be helpful, but balancing that with the well-being costs of isolation needs to be a consideration. I personally think that if you are communicating well with your patients and you are engaged with your patients, your risk of litigation is actually much lower as a result of that engagement. The burned out physician who cannot engage with his or her patients is actually more at risk of litigation. And therefore, if we focus on well-being, that emphasizes shared decision-making, time with patients, engagement with patients, and the risk of litigation goes down. It may not go down to zero, and I don't mean to diminish or belittle that consideration, but I don't think people should walk around thinking about litigation first and foremost in their practices. And if you're in a practice where that is what you're thinking about in your day-to-day with your patients, then I think that needs to prompt some reflection on how that aligns with meaning, values, and purpose. Again, not minimizing those concerns, especially in more litigious specialties or practice environments, but it can't be at the front of mind for everybody. Those are the chat questions that have been so far presented. If there are any other questions or comments, I'm certainly happy to take those. And certainly give people a few seconds to see if any of those pop forward. But while we're waiting for that, I would just thank everybody for your time this evening. If there are other questions or things that I can help any of you with, or if you're interested in copies of any of the references that I've cited, shoot me an email or send me a message on Twitter, and I'd be happy to share those with you. You know, again, thank you for everything that you've done during the pandemic. I hope you all can stay well and that your families can stay well. And if you have been infected yourselves, I hope that your recovery goes well. We're thinking about you around the rest of the country. And as I said, you've been role models in so many ways. And when you're in the middle of it, you don't know that. And but we've been around the rest of the country taking very careful note of what you've all been experiencing. Not a place any of you ever wanted to be, I know, on the vanguard of this sort of response. But we admire you, we respect you, we appreciate you. And with that, and not seeing any new questions, I think that's a good note to close on, with my appreciation of all of you.
Dr. West, can you
Yes.
hear me? It's Jerry.
Yes, I can.
It's Jerry Donahue to the crowd. Hi, everyone, and it's great for everybody to be here. Thank you so much for coming. I must tell you, Dr. West, you are absolutely a gift and a treasure to the profession of medicine. We are so lucky to have you. It's so necessary, the research that you're doing, that your devotion, and then to come and deliver it to us, it means the world to us. And we're so very grateful for you. And thank you so much for this terrific presentation. It was riveting.
Thank you, Jerry. Thank you to all of you. Stanley, is there anything else that you need, or are we good to close up shop for the evening?
All I need is for you to be well and everybody who attended to be well. And I thank you all for being here. And I thank you for a great presentation.
All right. Thank you, everybody.
Thank you. And thank you, Stan. Great moderation.
Yes, thank you.
You're welcome.
Good night. Be safe,
Great evening.
everyone. Bye-bye.
Thank you so much, Dr. West.